Hey guys, this is Dr. Dwain Woode from Diabetes and Endocrine Wellness Center and the Light Away in Huntsville, Alabama. Today we're talking about thyroid cancer. Cancer is the second leading cause of death in the United States, right behind heart disease. Today we're going to talk to a special guest, Dr. Neeta Dang, one of the otolaryngologists here in town, an ENT. Let's get started. All right. Well, good afternoon, Neeta. Thank you for joining us today.
My pleasure.
Awesome, awesome. We're so excited to talk about thyroid cancer. We see a lot of patients who come in to our office with nodules, and they get referred. So we're going to talk a little bit about what that process is like. But before that, tell us a little bit about yourself. What made you choose otolaryngology, and what types of things do you like to do?
Well, from a medical point of view, I like the practice very much. I'm very interested in thyroid surgery, sinus surgery, and we see a lot of patients complaining of dizziness as well. But we actually treat a multitude of different issues. I think what interests me is that it's a combination of medicine and surgery, so that you actually don't have to operate on every single patient. Some of them actually get better with medication alone, and few may require surgery. So I like that combination, and I've just always been interested in that field of medicine.
Oh, well, awesome. We're glad you're in that field of medicine. Well,
Yeah.
tell us a little bit about. So we're going to talk about thyroid cancer, but give us a little perspective. Where is the thyroid? What is it near? How can someone who's at home find their thyroid?
Okay, the thyroid is typically here, just above the suprasternal area, and it's below the prominent bone called the thyroid cartilage. Adult males actually have a much more prominent thyroid cartilage than women, and that's just the way we're made genetically. It's below that. However, there are people that have huge thyroid glands, and therefore you will see protrusion of soft tissue anteriorly. But typically, the thyroid lobe or the thyroid gland is pretty small. It measures about 4 centimeters on each side, and it's usually located in this area.
How common are thyroid nodules, right? Because that's, I guess, the most benign thing that we can see. And the thyroid, just like anything else, we have lumps and bumps. How common
Mhm.
are those? And tell us a little bit about that.
Thyroid nodules are actually increasing in incidence, and it is believed that by the time you're 60, 70%, 7% of people have thyroid nodules. Now, most of these are benign, but the concern is which nodule is benign and which one is malignant, and that's where the ENT or the endocrinologist comes in to determine as to whether they can be simply watched and monitored, or whether they will require the nodule to be removed.
Okay. And as I was kind of preparing for this and going back over some stuff, it seems like the nodules are more common in women.
Yes. Yeah.
I guess the older you get, the more nodules you can have. What are some
Yeah.
other things or risk factors or associations that we've seen with thyroid nodules?
Well, as far as thyroid cancers are concerned, within the thyroid nodules, there's a higher risk in women, and there's a high risk in people who have undergone head and neck radiation in the past. There's also a higher risk in people who have a family history of thyroid cancer. Um, those are basically the three main issues that we focus on when determining what to do as far as for the management of thyroid nodules is concerned.
Okay. So how does someone get to you? Um, do they just call you up, or how typically do you get patients into your practice?
I mean, they can certainly call us directly. We'll be happy to see them. Sometimes the family physician refers to us, sometimes the endocrinologist, sometimes an internist. There's a wide variety of people that will refer patients with thyroid nodules to us, but like I said, patients are certainly free to call themselves.
So someone, I guess let's walk through this together. Someone goes in, they see their doc, or they see an endocrinologist. They feel the neck during the exam, may think that they see a thyroid nodule or they feel a thyroid nodule. What would be the next step in that evaluation?
Well, we always start with the history. So we need to look at the age of the patient, and patients less than 20 and above 40 or 50 will have a high risk of thyroid cancer. I'm not saying they're all thyroid cancer, but we certainly look at the age. Men with a solitary thyroid nodule will have a higher risk of thyroid cancer. So we look at the age of the patient, the sex of the patient. We also inquire about previous head and neck radiation. We inquire about family history. So those are the main key things that we talk about. We also look for the size of the nodule, whether it has increased quickly, that is always a disconcerting sign, whether there's associated lymphadenopathy or enlarged lymph nodes, whether the nodule is actually fixed to the trachea. If it's hard and immobile, then that raises concerns. If the patient has developed hoarseness or difficulty swallowing, or especially if they have stridor, then we get extremely concerned. So that's the exam part. Now, we can certainly do thyroid labs such as TSH, FT3, FT4, but most of the time, thyroid nodules and abnormal labs don't go together, except for a patient who may have a toxic thyroid nodule and become hyperthyroid. Those are a separate category altogether. So we do order lab investigations. We will also order a thyroid ultrasound, which is actually considered more accurate as far as determining the shape of the thyroid lobe, the nodules, the associated enlarged lymph nodes, and assesses the thyroid bed in much more detail. So we usually start with the ultrasound rather than a CT. We would do a CT if the patient had a huge thyroid gland and we were concerned about whether it was actually tracking down into the mediastinum, and I've done a fair number of those. So you really want to know what's going on before you open up the neck and how much deeper you have to go down into the chest to scoop out that thyroid lobe. So that's when the CT comes in, but most of the time we're quite happy with the ultrasound. Now, most important is the fine needle aspirate, whereby a needle is put into the nodule and a tissue obtained or cells obtained. The tissue is spread over a slide, it's prepped and then sent to the pathology department. And that's really the crux of how we decide to proceed. If the needle aspirate is malignant, then it's pretty straightforward. We would consider surgery. If it is indeterminate, then we have the choice of repeating it or following the patient with another ultrasound in 6 months. And sometimes the patients just feel like they just want it out. There may be a strong family history of prior head and neck radiation, which would make us suggest that type of therapy. So those are the three main tests that we do as far as a thyroid nodule is concerned.
You mentioned a couple of things there that I want to come back to. So number one, it is possible to have a thyroid nodule or even thyroid cancer and the thyroid itself be functioning well.
Absolutely. Most of the time, the thyroid is functioning normally. And I try and explain to the patients that we're looking at two different issues. One is the ability of the thyroid gland to function. The other is whether the nodule is malignant or benign. So they're typically two different things. But yes, we do thyroid labs because if they are hypothyroid, then obviously we'd want to treat them. Secondly, if they are hyperthyroid, that makes us look into the possibility that the nodule could be a toxic nodule.
Well, the other thing that you mentioned was the Bethesda categories. And so those are 1 through 6, correct? And
Correct.
one being, I usually tell patients, we didn't get enough cells,
It's
essentially.
inconclusive. Yeah.
2 is benign, so there's not cancer there. 3 and 4 sometimes not we're not three. Definitely, we're not sure. And I think one of the studies that I read said that when they looked at these in the category 3, if it was indeterminate, it's usually maybe 15 to 20% cancer. If it's category 4, sometimes 45%. And then, of course, categories 5 and 6 are what we would say, yeah, these are cancers. Okay.
Yeah. The higher you go, the more the risk of it being a
The more the
cancer.
risk, right? And now, when I started training, all of the category 3s we would send to the ENT, and they say, hey, this is really something we should look at taking out. But now we've got some testing that we could do, the Afirma, which
Hmm.
can I guess risk stratify that for you.
Hmm. You know, the before I go into that, the main, the most common thyroid cancer is the papillary carcinoma, and the fine needle aspirate can typically pick that up. But when you come, the second most common is the follicular, and that's where the Afirma comes in. So follicular cells on fine needle aspirate would previously suggest that this is some kind of a neoplasm. It could be a follicular adenoma or it could be a follicular carcinoma. So in the old days, whenever follicular cells were noted and there was concern that this was some kind of a follicular neoplasm, we would basically tell patients, look, on a needle test, you cannot differentiate whether it's an adenoma or carcinoma because you have to look for vascular or capsular invasion. So we would take them out. And then more recently, a new test has come out, and that's the Afirma test that actually looks for genetic or molecular markers in the cytology. And it has totally, totally changed our approach to the follicular issue. And we have used the Afirma a lot. And it will come back basically saying that there's a 95% chance that this is benign. So we can reassure the patient, should that come back as 95% benign, that this is fine. We can continue to monitor you and maybe follow up with a repeat ultrasound in 6 months or longer, depending on what the situation is. If the Afirma is positive, or if they say, yes, the Afirma does suggest a high likelihood that this is malignant, then we would go in and operate on the patient. So the Afirma has really changed our approach to follicular tumors.
Okay, all right. And thank you for getting into the types. So there is the papillary, which I
Mm-hmm.
believe is the most common, 80%, I believe. Then follicular, and then Hürthle cell are the three general differentiated.
Right.
And I'm going to say these words, and I'll have you come back and explain them for me. So
Mm-hmm.
those are differentiated. There is the anaplastic, which is an undifferentiated, which is probably the rarest of the, well, not rarest, but a rare kind of cancer.
Thankfully,
And then the
because,
medullary thyroid cancer. So, what
right.
is the difference between differentiated and undifferentiated? Why do we use those words?
Well, it depends on where they're arising from. So the differentiated ones are generally more benign in their I guess pathophysiology. They arise from the epithelial cells within the thyroid gland, versus the medullary carcinoma, which is not part of the well differentiated group, arises from the parafollicular C cells or the neurocrest cells, and those are more aggressive. And then you've got the anaplastic carcinoma, which fortunately is very rare and also undifferentiated, and that is so aggressive that typically patients will pretty well not last more than 6 months. And should we decide to operate on them just to debulk the disease or to do a trach, the tissue, it's like just stone, concrete when you go in there. You can't really scoop out the thyroid gland. It's just stuck to everything. So the well differentiated ones are generally behave in a more, I guess, benign or less aggressive fashion, and they come from the epithelial cells. The most common is the papillary, as you said, and then the follicular and the Hürthle cell are kind of cousins, and they are the second most common. They are more aggressive than the papillary. Their 10-year survival rate is 85% versus the papillary, which is 93%. So they are more aggressive, and they do the follicular carcinomas or the Hürthle cell carcinomas spread can spread through the blood vessels. So there's vascular invasion. So they can go to the lung, the liver, the brain, the bone, versus the papillary, which is fortunately the more common one, tends to spread to the lymph nodes. And studies have shown that even when they have enlarged lymph nodes, it doesn't necessarily alter their prognosis, which is a very fortunate finding as far as we know right now. The third one, as we said, is the medullary carcinoma, and they arise from the parafollicular C cells, and they are from the neurocrest origin. They 30% of them will have a familial history, and they can also be part of the MEN2 syndromes, or the multiple endocrine neoplasia syndromes. And there's the MEN2A and the MEN2B. When you get a final aspirate that suggests medullary, that sets up red lights everywhere because they're totally different. The
Okay,
other
good.
thing is, if we have concerns that this is a medullary, we have to start doing genetic testing like the RET oncogene, because that is associated with medullary carcinoma. And if that is positive, then all the family members have to be investigated as well. So it's a totally different animal, so to speak, and needs much, much more aggressive therapy, not only with a total thyroidectomy, but with bilateral neck dissections. They don't respond to radioactive iodine or, the more conservative methods we have available for papillary carcinoma.
So as we go down the path of, okay, now we've got a biopsy or fine needle aspiration that either suggests that there's cancer or was indeterminate, and we got an affirma, and the affirma suggests there's a cancer, and so
Okay.
they come to you. What do you do next?
Well, it depends on the size of the nodule, but typically, if it's a follicular carcinoma, we would consider taking out the entire thyroid gland. And we would do a total thyroidectomy. The patient would be asleep for about 2.5 hours. The procedure, the recovery is not that bad. They stay in hospital overnight. They will have a drain to, aspirate any residual blood left in the wound. I find that no matter how perfectly dry the wound appears, there's always some drainage to the hemovac overnight. I guess when patients move, they cough, they swallow, they talk, there's a little bit of oozing that develops in the surgical bed. They typically go home the next morning. The most important thing is to monitor their serum calcium, because the parathyroid glands, and there's a total of four, two on each side, and we're very careful to dissect off the parathyroid glands, off the thyroid capsule. Sometimes the glands will just stop working because they're just annoyed that we've gone near them. And the majority of them recover within 6 to 8 weeks should the calcium drop. But the risk of that happening is actually less than 5%. Most of them, the calcium remains within normal range and they go home fine the next morning. It's very important that we give them thyroid hormone, post-operatively, because they really have no thyroid gland. And then we take it from there.
Okay, so sounds like in the scheme of surgeries, can be a pretty good one. So they come in, if they do well overnight, the drains
Yeah.
don't have a lot of drainage. They go home the next day. We've started them on some thyroid hormone. So let's pause there for a minute. And so one of the questions I get is, one, did I do something to get this? Okay. And am
Right.
I going to have to take medication for the rest of my life? How do you
Well,
respond to those two questions?
um, I don't know if they did anything to get them. Now, obviously, if it's a medullary, then there's a genetic component to it, but typically not in follicular. However, there is increased risk of cancer with previous radiation, so that's important. So, yes, that could be an issue as well. As far as taking medication, yes, you have to take thyroid hormone for the rest of your life because you really don't have any gland left. So that is critical, and they're aware of that preoperatively.
How do you make a decision between a lobectomy, and a total thyroidectomy?
So it depends on the pathology. If it's a medullary carcinoma, we would do a total thyroidectomy. If it's a papillary carcinoma, papillary is supposed to be multicentric. So a few years back, and this has changed altogether, but a few years back, if surgery was done and the findings came back confirming that this is papillary carcinoma, but it's a very small one. Um, at this point in time, we wouldn't do anything more. We would say, that's it, we're just going to monitor you. Now, if the patient has a large papillary carcinoma or there's evidence of lymph node involvement, then we would certainly do a total thyroidectomy. But the literature now is suggesting that we turn to a much more conservative approach. So previously, if there was a papillary, we would say, oh my gosh, papillary can be multicentric, and we need to really take out the whole gland because we want to make sure there's no contralateral disease. As well, by taking out the whole gland, we can give them radioactive iodine and not take the risk of the contralateral lobe picking up the radioactive iodine and therefore technically wasting the medication. The third issue is that these patients could then be followed with a serum thyroglobulin level, which should really be very, very low unless there's a recurrence of cancer. So that's why previously a total thyroidectomy was recommended. But things have changed, and the Japanese actually first introduced this conservative option, and now it's been accepted here in the United States. So if it's very small, we really don't go back in and take out the other side. We give the patient that option that, listen, we could just monitor it. We do serial ultrasounds. Now, if there were nodules on the other side that was smaller than 1 centimeter and therefore not amenable to a needle aspirate, we can say we can't be sure that there's no cancer on that side, but we could simply follow it because these cancers tend to be less aggressive. So part of it is what we recommend, and part of it is what the patients prefer. And some of them will say, I'm fine. I'll just have my ultrasound in 6 months. If there's no change, then we can continue to follow the patient. But if the nodule starts to grow, especially if there's a history of papillary carcinoma, then we'll say, maybe that's a good idea to just take out the other side and be done with it. So there's a lot of back and forth that happens depending on the size of the tumor, what we find intraoperatively, what the contralateral lobe looks like, what the patient prefers. So it's not like, oh my gosh, we just need to take it all out. There's different factors that come into play. And a lot of it also depends on what the patient wants. So, it's not that we dictate the treatment, we can only make recommendations.
Well, it sounds like, so, we've just talked about the patient maybe seeing their primary care doc. Maybe they come to an endocrinologist like me or go directly to you to do surgery. The next step for some patients is seeing a radiation oncologist, right?
Yes.
So they get the radioactive iodine ablation. And how is that kind of determined? I know a lot of it is based on the extent of the thyroid, the cancer spread, the size of it. How do you determine if someone goes to an oncologist or comes, like, for instance, back to me, or what's your thought process there?
Again, if it's a large, let's start with papillary because each one is different. If it's a large papillary carcinoma, especially if there's lymphadenopathy of, paratracheal extension or extracapsular extension, they come under the category of being more aggressive. So there's the mildly aggressive, moderately aggressive, severely aggressive, or, they're categories. So if they fall into the significantly aggressive category, then we do send them to the endocrinologist and say, hey, do you think this patient could be a candidate for radioactive iodine? Now, they don't always get it. We send them to the radiation oncologist and they may say, yep, I think we should do it. Or they may say, I've looked at the pathology and I've looked at the op notes, and I think maybe at this time we don't need to give it. Just because you don't give it at that very moment doesn't mean you can't give it later. So it really depends on how large the tumor is. So if the tumor was, as I said, a centimeter or 2 centimeters, or relatively small, localized, no pericapsular invasion, no vascular invasion, no tracheal extension, no lymphadenopathy, then we would probably not give them anything more, but we would follow them and
Okay.
then send them to an endocrinologist who would, follow them with serial ultrasounds, make sure their lab indices are normal. And also, when they have a history of cancer, we like their TSH to be on the low side, so that there's no stimulus to for the gland to grow, any residual cells to proliferate. Obviously, if it's a total thyroidectomy, there's not much of gland left.
Right, right, and that sometimes is one that is a little interesting for patients to get, and so we call that suppressive therapy, right? So where
Yes.
we are giving thyroid replacement to the point where we actually are taking the TSH,
Way down.
most often to a sub
Yes.
a sub normal level, usually between zero point 0.1 and zero point 0.5.
You're over.
Right. So that, and then we monitor the thyroglobulin.
Mhm.
Now, traditionally, the thyroglobulin was a good option to monitor when someone got radiation, the radioiodine. But if they didn't get radioiodine, sometimes it can be a bit tricky to
Yeah.
know, is this something that is just their norm, or is this because they didn't get the or this is this thyroid cancer recurrence?
Right. Right.
So looking at all of the various types of thyroid cancer and looking at the 5-year survival, it looks like papillary, follicular, and even Hürthle cells are pretty good, even if there was distension or where those cells showed up in other parts. And I
Mhm.
think with Hürthle cells, like 74% at 5 years.
Yeah.
Anaplastics, not so
the-
much. I think it was down to 7% at 5 years if they had extension, and 38% 5-year survival, like you mentioned earlier.
Papillary is the best. The mortality rate is 7% over 10 years. And these patients, they may have recurrences years later. So it's not a slam dunk where they have their surgery, everything's fine, go home, be happy, and have a great life. They need to be monitored because they can have recurrences years later. So it's not a 1 year follow-up, it's a several year follow-up.
Right, right. Okay. Well, so I mean, I appreciate that you came and talked with us about this. Anything else that a patient needs to know? Any other question that you could think of that they might ask that we need to give some more information about?
Well, I think they're always concerned about the size of the incision and discomfort.
Mhm.
And if you look at the old pictures, I mean, they'll have an incision all the way across, and we don't do that anymore. We'll try and make the incision as small as possible. In fact, my partner and I kind of joke with each other, like, "Gosh, can you not make the incision any smaller?" But at the same time, if it's a huge thyroid gland, then we cannot make the incision too small because we have to get the gland out. Okay, so this is a video showing the recurrent laryngeal nerve, which is a nerve that supplies the voice box, and you can see that we've identified it. The probe is actually the nerve stimulator, and when you apply it next to the nerve, you'll get a beeping sound, which is basically a confirmation that this indeed is the nerve. So it's a very gratifying sound to hear in the operating room. So, no, we don't make a very long incision. Most of the time, we make it about 1.5 inches or 2 inches. We try as best we can. As far as scarring, I typically inject all my incisions with Kenalog to reduce hypertrophic scarring, and that helps a lot. As far as pain, it's typically not a painful procedure. The majority of people don't have much discomfort, but there are a few that have neck pain. But regardless, we give them all, narcotics to take post-op if they need it. As far as diet, they can have anything they want afterwards. They have a regular diet, maybe soft diet to start with, and then build up very gradually. The next morning, the drain is removed. Typically, I say if it's 10 cc's or less, the drain can come out and they can go home. The main thing as far as driving is concerned, they may not want to drive the first 5, 6 days or so, because when they turn, to look at your blind spot, they're pulling on the incision and that may be a little uncomfortable. Otherwise, it's not a very uncomfortable or painful procedure to recover from.
Well, do
In the
you
middle.
have a website? How can
Yeah,
someone reach you if they need? Can you give us that information?
sure, sure. We'll add a link. The website is HuntsvilleENTphysicians.com, and we have several videos there, not regarding thyroid surgery, but other videos if patients have other concerns that they want to look into. And like I said, if they are concerned about their thyroid nodules or masses within the neck, by all means give us a call and we're happy to take care of them. As far as hypo or hyperthyroidism, we usually recommend they see the endocrinologist first, because that's typically not something we treat routinely, unless they just happen to develop that while we are in the midst of treating them for other conditions.
Well, and you just got my brain going there. So I hope that you will allow us to bring you back, even if it's a non-endocrine
Yeah,
ENT
sure.
issues that we could talk about. So we want to thank Dr. Neeta Dang again for joining us and sharing some very important information on thyroid cancer. Hey guys, look, if you're getting benefit from the topics that we're covering on this YouTube channel, go ahead and hit the subscribe button. Also, click on the bell so you'll be notified when we provide new content. If there's something specific that you want us to cover, some topic, go ahead and send us a comment or drop us an email. We're always looking to develop new content and we're always working to educate our public. Thank you for joining us today. This is Dr. Dwain Woode from Diabetes and Endocrine Wellness Center and the Light Away, educating the public for a better you.